I am just so thrilled for you to meet probably one of the loveliest people I think I've ever had the good fortune of meeting. Is that fair?
That's incredibly humbling, but thank
But
you.
it's true. Well, everyone, we've had such a great lineup of speakers from Sadie and Gina and Jacob and Karen, and now you get to meet Dr. Steve Wengel. He's originally from Omaha and received his bachelor's degree from the University of Nebraska in Lincoln. He went on to receive his medical degree from UNMC and then followed that up with residency in geriatric psychiatry as well as psychiatry from Creighton University and UNMC. Dr. Wengel has been practicing geriatric psychiatry since 1991. He sees patients in his office and at several long-term care facilities in and around the Omaha area. He's an active and, I guarantee, enthusiastic teacher of student residents. Dr. Wengel has also served UNMC in several administrative roles, having served as the clerkship director and then department chair. In 2018, he became UNMC and UNO's first Assistant Vice Chancellor for Campus Wellness. And in this role, he's developing strategies to reduce stress and burnout in students, staff, faculty, and healthcare professionals. His vision is to improve the physical, psychological, and social well-being of all who work and learn in the healthcare world, the academic environment, and the community at large. Please join me in welcoming this very good soul, Dr. Steve Wengel.
All right. Well, good morning. Good morning. Delightful to be here, and we will get started. And I know I'm the last person between you and lunch, so I will end on time, even though I know we may have gotten a little bit of a late start here. I'm going to be kind of rude and sit because I have a bad knee and I can't stand for very long, so I hope that's okay.
Yeah.
If not, I'm going to do it anyway, but I need to stand for me. Appreciate that. Okay, so I am, yes, a practicing geriatric psychiatrist. As you can see, been doing it a while. That's half my job. The other half is this kind of wellness gig. That's another story. But lots of burnout in my world in healthcare, and so that's the other half of my job. But my two worlds actually coincide quite a bit because I work with a lot of caregivers. As you heard from Sadie, and as you know, I'm sure firsthand, being a caregiver is tough. And so it's interesting how my worlds collide, trying to reduce stress in nurses and physicians and such. I've learned a bunch of techniques, so sometimes I use that in my clinical world too, helping caregivers as well. So anyway, let's get into the topic at hand. I'm going to talk about the concept of capacity. So here's what I would propose to you for what we're going to try to accomplish in the next 50 or so minutes. Talk a bit about capacity, and incidentally, I hope I'm coming through okay. I'm heard with, okay, so you folks can hear me, hopefully people in the other room can hear. Talk about capacity and competence, and these two concepts I think get muddled together quite a bit, including with physicians, so I had to kind of relearn some of this myself, but hopefully I'll make it clearer. Then we'll talk about some common medical problems that can impair one's ability to make good decisions. And I'm mostly going to talk about making medical decisions because that's my world. I'm not a lawyer, I'm not a forensic psychiatrist, so I don't deal as much with making legal decisions about how to manage your estate and making wills and things like that. Fortunately, you have actual legal experts I know this afternoon. But then talk a little bit about where do you go for help. If you have a loved one with these, or a client, or whatever your role might be, where you suspect they might have some decision-making trouble, where can you go to get that sorted out? Again, does that sound like a reasonable agenda? Good, thank you. Again, I'm going to do it anyway, but thank you for your affirmation. It makes me feel better, so that is great.
Okay, I hope I didn't go forward on you.
Yep, nope, we're good. And so a few definitions. Oops, let's see, there we go. So I mentioned, let's start with just the first one. So competence or competency. Let's see, for some reason those buttons are not working right. Oh, there we go. They're just lagging maybe. There we go. So technically, to declare someone incompetent, you have to be in the legal system. You have to be a judge, I believe. So I can't do that as a healthcare provider. And it's a yes or no dichotomous thing. You either are competent or you're not, as I understand it. But my world, that overlaps quite a bit though, is looking at capacity. Oh,
Steve, if we could stop for a
Yep.
second. We have, believe it or not, we are muted.
Oh,
So,
oh,
Yes, so.
okay. So
I'll
maybe
tell you
back
what,
up a
let's
bit.
go, if you'll go back here, I'll just show you real quick where
We're
it is.
just actually thinking of more stuff we can do to interrupt you.
Yeah, there you go. That's right.
So,
That's
here,
right.
can you go up here for a second?
Kind of like live radio, you know? You just never know.
But it looks like it's live now. Maybe if the interpret, okay, I see a thumbs up.
Yeah.
Okay, very good.
Okay. Do I need to back up at all or review anything, or just keep plowing ahead? do you
How
think?
far did you get into this,
Just very,
Steve?
not very far. I mean,
Okay, maybe back it up just a minute,
Yeah,
and thanks for your patience.
certainly. Well, let's see, I will try to back it up. Huh. Okay, let's see. Well, let's try the mouse here. A little difficulty.
Is your screen?
It was, yeah, it's kind of locked up, but now it seems to be, well, nothing. There we go. Now we're working. Okay, all right.
All right, thank you for your patience
My
with us.
pleasure. All right. So again, just real briefly, these are kind of what we're going to do here in case you missed it because of the muting. Sorry about that. We're going to talk about capacity and competency, and then mostly as they apply to medical decision making, not so much to legal decision making. Talk about common medical problems that get in the way, including dementia, but also a few other things. And then talk about some referral sources. Where can you go for help? All right, so back to this. So competency, again, is a legal definition. A judge has to make that determination. I can't do that. And you either are competent or you are not. It's either or. There's, as I understand it, not really much middle ground. But my world, this is something that I have more of control over, is declaring someone's capacity. Does someone have capacity or do they have incapacity? And it's kind of a sliding scale. There are various degrees of capacity. So I can declare, someone to have low capacity or to not appear to have capacity to make medical decisions. I can't declare somebody competent or incompetent. Some other basic concepts. So, as you might imagine, everybody is it's kind of like in a court of law. You're innocent until proven guilty. So here you're competent or you have capacity until you don't, until it's been proven that you don't. So it's assumed, like everybody in this room and me presumably, have capacity, right? But it can change, So any of us can get sick and temporarily have problems, like from delirium, and I'll talk about what delirium is. But it may come back then, so that's the good news. So you may lose capacity temporarily, but it can come back. Sometimes it doesn't come back, depending on the condition. And, there we go. It takes a high degree of proof. We don't want to take this lightly, to take away somebody's decision-making, capacity or their autonomy. So we want to make sure we do it thoughtfully and accurately. And as you might imagine too, we're going to set the bar higher for high-risk decisions. So in other words, a person may have capacity to decide to take a new medication for high blood pressure or chemotherapy or whatever, as compared to agreeing to a risky operation. That requires a higher degree of capacity, as you might imagine. So some elements of this. So if you think about it, I was thinking about this myself. So I can list the elements of capacity, but if you actually just think about it logically, if you're thinking, okay, if I'm working with a friend, a loved one, significant other, and I want to make sure they really understand what they're getting into. They're trying to decide whether to have this operation or this procedure or not. What would logically make sense to ask them? Well, do you know what the procedure, what did the doctor say? Let's say you send your significant other to the doctor and they say you have this condition and you need this procedure. You're going to start asking them some very logical questions when they come back. What did the doctor say? What do you have? What's your condition? What do they recommend as the treatment? Oh, okay, that's interesting. You need this or whatever. What are the risks of that treatment? Are there alternatives to that treatment? And so forth, right? So kind of logical questions. So that's really what it comes down to. So do they know what condition they have, at least in basic terms? Do they understand in general what kind of treatment's recommended? Do they understand, the risks and the benefits, because everything has risks and benefits. Whether it's a medication or a procedure or whatever. Do I need to stop, or we
No,
have a
you
meeting?
keep going, I was
Okay.
trying to figure out why this is on here.
Yeah, okay. And then, of course, what are the alternatives? Because there are almost always alternatives to the treatment. One of the alternatives being no treatment, And then, can they demonstrate some sort of reasoning too? That's another piece of this too. Can they, can they kind of demonstrate that they're making a logical choice? They're not just sort of making it up or, flipping a coin, that they actually are showing some sort of logic. It's kind of like math teachers, show your work. It's not enough you get the right answer. Can you show your work? And then can they communicate their choice, which is different, when you think about it, than making the choice. Can they articulate it and so forth? Okay. Here we go, just kind of lagging behind. Okay, so what are some signs where somebody might have a capacity problem? So if they're not thinking logically, and I'll give you some examples here in a minute. If they abruptly seem to change in their cognitive ability, like they wake up and they seem pretty confused, that's not a good time maybe to be asking them to make big decisions. If they refuse what seems like an obviously beneficial treatment that most people you think would reasonably say, well, yeah, I think I should do that. But by the same token, this is the one that catches you off guard, if they say yes too quickly to something pretty risky without really thinking it through. Okay. All right, let's see, let me make sure I didn't miss something again that's a little quirky here. Okay, there we go. Okay, some of the other risk factors. So, somebody that's really fearful in healthcare settings, which is a lot of people, and I get that. I work in a healthcare setting, but when I'm a patient, it's different. I get anxious like anybody else, right? So if you have overwhelming fear, that could get in the way of your decision-making capacity. Young people and people over about 85 statistically have a higher risk for having difficulty making decisions. Obviously, if you have a chronic illness, whether it's neurological, medical, psychiatric, whatever, low educational level. Now, again, that doesn't automatically mean that you lack capacity just because you don't have, a fancy degree, but it statistically makes it maybe a little more likely. And then cultural or language barriers, too, as you might imagine, can get in the way. So one way of looking at this from a clinical point of view, remember, I'm not a lawyer, I'm a psychiatrist, I'm just somebody in the trenches trying to take care of my patients. But when I try to teach this to my students, I've come up with, rubrics like this. And I will be using a version of this next week when I get to teach in Dr. Masters' class to some undergrads. So the 5 Ds, real basic things that happen in taking care of older adults: delirium, dementia, drugs. In this case, I'm not going to talk about street drugs, but prescription drugs, and a little bit about depression and delusions. And again, I'll give you some actual cases here in a bit. And incidentally, when I talk about patients, and I have cases up here, these are sort of slightly fictionalized cases that I've gotten out of the medical literature. They're not honest to goodness patients, so I'm not going to, because of HIPAA and privacy and all that, I'm not going to talk about my own patients, of course. So let's talk a little bit about delirium. So delirium, you've probably heard the term, almost certainly, but I think there's a lot of confusion about delirium, and which is ironic because delirium it causes confusion itself. But the name delirium, so sometimes I refer to it as temporary brain failure. That's not an official legal term, but that's just my kind of term, or you can call it brain dysfunction. But it's usually temporary. It's usually caused by an acute medical problem. Now, those of you taking care of older adults, especially older women, are quite familiar with the concept of urinary tract infections and UTIs. Very common, especially in women. Men can get them too, but more often in women. And I don't know why, but there's some sort of magical connection between the bladder and the brain. And when older women especially get a UTI, it is very, very, very common that they get delirious. They get a little confused, a little forgetful. You clear up the infection, and by golly, it gets better. So in my nursing home work, if a nursing home calls me about one of my female patients and said, Mrs. Jones, who also has Alzheimer's disease, now seems much more confused, the first thing I do is say, have you gotten a have you checked their urine recently? Because that's 9 times out of 10 what's going on. But other things, pneumonia, electrolyte problems like low sodium, Clearly medication side effects, and we'll talk about that later. People that are post-operative, as you might imagine, or you've probably seen. And then this last one though, the mental clarity often goes up and down. It's not a fixed thing. And so people with delirium especially, it's really pronounced. That we have a joke in medicine that like a medical student might be seeing a patient, well typically the way we do rounds in an academic health center, the medical students come really early in the morning, like 6 in the morning, they go around and see the patients on their own, and then the attending physician comes much later. They get to sleep in a little bit, but they come in and come in about 8 o'clock, and they ask the student, well, how's Mrs. Jones doing? We fixed her hip yesterday, how's she doing? And the student says, boy, she was great when I saw her earlier today, she was alert, she knew what day it was, she didn't have much pain, she's doing great. And the attending physician says, hey, fantastic, so they go in and go see her together, now it's 8:30, and Mrs. Jones is bouncing off the wall, and she thinks it's 1945, and she thinks Hitler's coming, and who knows what, she's just confused and really delirious. And so the attending physician thinks the medical student kind of dry labbed it because she's very different than she was described. But that's what delirium can look like. 2 hours later, they can be acting very, very differently. And then in 2 hours from then, they might be clear, their thinking might be clear again. So that's pretty common. So here's an example. Here's one of those fictionalized cases. So an 88-year-old woman lives alone, comes in to the hospital after a fall. And that's a common thing that brings people into the emergency room. And they check some blood tests, and common thing to check is electrolytes, and they find that her sodium is low. So 120, just take my word for it, that's a very, very low number. Should be at least 135. So when it gets down to 120, that's enough to make your brain not work right. Your brain needs a lot of things to go well to work right. Enough oxygen, enough blood sugar, enough sodium in your blood, and so forth. So when your sodium starts getting to 120, your brain doesn't like that to make you delirious. So she gets admitted to the hospital, and it's potentially life-threatening. So you have to admit people to the hospital, and you need to gradually get that sodium to come up. Then they find, while she's in the hospital, she hasn't been taking her heart failure medicine for a while. That's probably why the sodium is low, because she hasn't been getting rid of, she's probably on a diuretic, and so she's, not getting rid of fluid like she should, and so forth. So anyway, but her sodium comes up and everything works and she survives all of that, which is good. But by the 3rd day, she's feeling better enough, she wants to go home. And they examine her though, and they find that her muscles are quite weak, and that's maybe why she fell. And she really can't even get out of bed without assistance. But she is absolutely determined, I'm okay, I can go home and be by take care of myself. Whereas the hospital team thinks she really needs to go to rehab and get some physical therapy and so forth, but she refuses. Does she have capacity or not? What do you think based on this? Who would vote? Okay, the people I can see in this room. Who would say that she has capacity? See, a couple hands. Who thinks maybe she doesn't have capacity? So some hands are too. So it's a mixed bag. So you can't really tell from what I've told you, but this would be somebody where we would certainly want to check it out and make sure. So in other words, the hospital team is probably not going to automatically rubber stamp and say, well, you want to go home? We don't think it's a great idea, but we're going to let you. They're probably not going to do that. They're probably going to say, we need to check this out further, maybe bring in a psychiatrist or someone else to kind of check out and see, how is her cognition? How is her thinking? She may still, even if her sodium got corrected, she's probably still, her brain is still healing from that, and so she may still be a bit delirious here. We don't know. Don't know from what I've told you here, but it certainly bears looking into, I guess. Okay, a word or two about dementia, and you're going to hear a lot more from Diane Hendricks later, but just real briefly, delirium is temporary usually, but dementia is usually permanent. And as you've heard from Sadie, we often use, and I thought you said it really well, Sadie, that we say Alzheimer's and dementia kind of in the same breath, and as you heard from her, dementia is the big broad term, and Alzheimer's is one of 50 plus types of dementia. It is, as you heard, by far the most common type, so we often use those terms, but they're not quite synonymous. Alzheimer's is a form of dementia. So everybody with Alzheimer's disease has dementia. Not everybody who has dementia has Alzheimer's. Belabored that more than I need to, probably. But that's that. But what are some other common? So vascular dementia is usually thought to be the second most common, caused by maybe tiny little strokes. Parkinson's disease can cause dementia, not always, not everybody with Parkinson's gets dementia too, but many do. You may well have heard of Lewy body dementia. When I first started doing this work back in 30-some years ago, most people had not heard that term, but I think now it's a pretty commonly used term. It's a pretty common type of dementia. But then there's frontotemporal dementia, which is a rarer form of dementia, which is hard to pick up sometimes because it doesn't cause a lot of memory problems. The other forms of dementia cause mostly, initially, memory problems. People are forgetful, they repeat themselves and so forth. People with FTD or frontotemporal dementia don't do that so much. Their memory is pretty good, but their ability to process information and think clearly is not so good. And I'll give you a few examples of that later. I don't have time to go into a lot more detail, but this is one that catches you off guard, I think. And then, of course, substance use disorders. People with severe, alcohol use disorder sometimes have dementia because of that, and other forms of substance use disorders sometimes can produce dementia. These are just some of the common things. There's many others, but those are some of the most common ones. Okay, here's another case. I really think these cases, I find them helpful because, it puts a face on this, right? So here's a 72-year-old person who comes to see her primary care provider as an outpatient, getting ready to have elective hip replacement. So just like me, I'm gonna have my knee replaced in January, so I gotta go see my PCP in December to get ready, have that done. So she's the same way, she's getting her hip replaced. She has mild Alzheimer's disease. Oh, red flag. Doesn't mean, incidentally, just the fact you have Alzheimer's disease doesn't mean you lack capacity. But it is a red flag saying maybe we better think about this. So her physician says, well, let's just be careful. So let's do what's called a MoCA test. How many people in this room have heard of the MoCA? So most of you, not everybody. So the MoCA test, I'll show you a picture of it later, is a very commonly done kind of cognitive test. It's a 30-point scale. 30 is perfect, 0 is terrible. We usually figure 26 and above is kind of normal. So she scores well below the normal cutoff. She's 21. So, okay, what does that mean now? And so her primary care doc says, okay, I better ask her some more questions. Does she know what she's getting into? So it goes through some of those same questions we looked at earlier. Do you understand what's your condition? Well, I've got really bad arthritis. What's your orthopedic doctor think you should do? They will fix my hip. Okay. And then when the doc asks her more about risks and benefits, or do you need to have this, or are there alternatives to having surgery? She just kind of smiles and vaguely says, it'll be okay. Okay, so what do you do with that information? So again, we have to then flesh this out more. Now it's one thing, it's great that she trusts her doctor. That's a great thing, obviously. But we need a little more than that because there are risks to the procedure, the anesthetic and bleeding and infection. The other thing that I didn't put in here is when the physician grills her a little more, I shouldn't say grill, but asks her a little more about it's not a police interrogation,
No.
right? But as they ask him some more questions, they say, and what happens after the surgery? Well, then I guess I get to go home. No, because she probably, in her case, would need to go probably for rehab for a bit. And she doesn't really understand that there's going to be some pretty intensive physical therapy. And that's one thing, I found when I had my other knee done, that physical therapy is part of the plan, and you got to sign up for both. You don't just do the operation. She gets half the equation right, but not the other half. So she probably doesn't really have full capacity for making this decision. Okay, a word or two about drugs. And again, remember I'm talking prescription drugs here. So here's an actual real-life picture that somebody took of their parents' medicine cabinet. I don't know if people still use medicine cabinets, but houses used to be built with that mirror that was on a hinge, and you'd keep your medicines there. Probably not the best place to keep medicines, incidentally. But anyway, this is not an unusual scenario. And here's another thing where a family member decided to sort their parents' pills out, and very colorful, I would say.
Wow.
Lots of, so the average older adult, that is of average health, takes something like 7 to 8 prescription medications. That's the average person, but some take many more. Now, certainly many of these drugs, whatever these might be, can be life-saving, help with high blood pressure, heart disease, diabetes, you name it. But, sometimes you can have too much of a good thing. And so when people come to our geriatric assessment clinic at UNMC, for example, and Nebraska Medicine, we have a pharmacist. We have a full-time pharmacist, and that's one they do is go through the medication list. What can we get rid of? So there's even a term for that now, de-prescribing. So we talk about prescribing a lot, but de-prescribing is a new verb. Can we get people off of medication when it's appropriate? Anyway, I could go on, but just, this already. The drugs are a two-edged sword. They can save lives and make lives better, but sometimes some of them can make things worse. make some conditions work. Okay, well, moving on to another D, depression. So something I treat every day in my clinic. Really bad depression can cause a person to actually become psychotic. Have delusions and hallucinations. Not super common, but it does happen, and we see it. So hallucinations that occur in somebody with really bad depression will typically have this sort of tone to them, no pun intended, but they will hear a voice telling them, or maybe several voices, telling them how bad they are, how evil, how dreadful, telling them they are responsible for all the sin in the world, for example. I mean, these really horrible things, as you might imagine. Or sometimes it's a chorus of voices talking about the person, but they usually have these negative, horribly negative themes. Now, delusion is a false belief, not a voice, but it takes the same tone, so that, again, a person with severe depression may believe, again, without necessarily hearing a voice, they may just have this belief that somehow they are responsible for all the evil in the world. And another thing that happens that we've seen over and over again, and I think Diane will back me up, that sometimes they have this delusion that they're financially destitute. I have no money, even though they're actually pretty comfortable. And imagine how that could influence your decision about having a procedure, right? Well, I need to have my hip fixed, or I need to have something, and the doctor tells me I need to do this, but I can't afford it. And it's like, well, first of all, you have Medicare, which will cover a lot of it, and you have a supplemental policy, and that'll cover a lot. And incidentally, I understand you have, this much money, or you have enough money in the bank to pay for it. No. And you can't talk them out of it. Logic doesn't apply when people are delusional. You can try, but delusions are really interesting. They really defy logic. So you can show them their bank statement, say you've got $50,000 or $100,000 in the bank. You can cover this, and they say no. I'm poor. And they turn their pockets inside out. So bad time to be making big decisions when you have that bad of a depression, as you might imagine. But it's treatable. That's the good news. Here's another case of somebody with delusions, not in this case from depression though. So here's somebody, a 56-year-old gentleman with schizophrenia, comes to the emergency department, brought in by a family member, by his brother, and he has a really large wound on his leg that's infected. So it's probably been going on quite a while and not being attended to. But, and probably not telling anybody about it, but the brother probably made a visit, maybe the brother's coming from out of town and sees this and of course gets really worried, brings him to the emergency department. So the brother then relays the information that, that my brother has diabetes but hasn't been taking medication for a while. Well, that could certainly increase the risk of having a big infected wound. So the doctor's talking to him and examines the wound and all, but just in talking to this gentleman realizes he's not thinking in a very organized way. His thoughts are real scattered. He has trouble. One sentence doesn't connect to another sentence. He's just going to talk about all kinds of unrelated things. And then in the course of this, manages to talk about having auditory hallucinations. So he's hearing voices. In people with schizophrenia, that's very, very common. Auditory hallucinations, really, really common. So he refuses treatment on the basis of the fact that the government is trying to kill him. And so if I come into the hospital and I, let you take care of me, the government will kill me because, the government is part of this hospital and you're part of the hospital doctor and you're all trying to kill me. It happens. Saw a lady just yesterday in one of the nursing homes I go to that has very similar delusions and thought I was part of the conspiracy. In fact, she thought all the staff at the facility where she lives are the undead. And I don't know if it's a Halloween thing or what, but she really thought that the nurses were the undead and that now I'm maybe and part of that too. So they get into all sorts of conspiracy things and just really deeply held beliefs that you cannot talk them out of. Okay, so there's some risk factors, but what do we do? How do we assess capacity? So first of all, look into things like communication because that can get at simple things, right? Somebody with bad hearing or bad vision, make sure that if they need hearing aids, that they've got them, and if they need glasses, they've got them. Using simple but not condescending language. We use a lot of jargon in my field. I suppose every profession has its jargon, but medicine certainly has lots of jargon. We throw it around. And, I remember somebody did a study one time where they went to, it was like Jay Leno used to go on the street and interview people, the jaywalking or whatever. So used to do a study they just went on the street and they asked people, they gave 10 really common medical terms. Said, what do you think the word X means? And I remember one of the examples was, what do you think the word dilate means? Now, dilate really means to enlarge or to make wider, but most lay people thought it meant to make smaller, for example. So we're going to dilate your pupils. Oh, why are you going to do that? Why are you going to make them small? You should be making them big. Well, you misunderstood the word. So we throw around a lot of jargon, and we assume our patients know what we're talking about because they nod out of politeness, but sometimes they don't really understand because we're speaking different languages and they're too polite to say something. Obviously, we're going to look for these reversible causes of capacity like delirium, like depression, and so forth. Again, drug, not substance problems so much, but prescription drugs getting in the way. Think about culture and values. Where's that patient coming from in their belief system? What if somebody, again, refuses blood transfusions and they just, no, I don't want blood transfusions. And you don't realize it's because of deeply held religious beliefs, for example. That may not be a capacity problem. That's a belief thing. So here's some questions we can ask, and so what's your again, basic stuff. What do you understand about your condition? That's the first question. Do they understand they have an illness? And what are the options for treatment? What do you understand about the benefits? And I like this other one. What are the odds that the treatment will work? Because what were they told? Oh, it's 100%. Well, I don't know of anything in the world that's 100%. What are the risks of the treatment? What are the odds that you'll have a side effect? What if nothing is done? What if you just decide not to do anything? Because that's a legitimate choice sometimes. Some other questions. And I like this one. Again, I got this out of an article, but it said, tell me what you really believe about your medical condition. Because sometimes people just parrot back, well, the doctor says I have osteoarthritis in my hip. What do you really think? Well, that may be a different answer than what the doctor said. And do you think that operation or that CAT scan or that whatever is best for you, and why or why not? What do you actually think will happen to you if you decide to do it, or if you decide not to? What fact? Again, common sense questions, but I think kind of good ones here. And then last one gets at that logic. It's one thing to understand the information. Like, okay, the doctor says I have a bad hip. They think I should have it fixed, and here's but. Can they connect the dots? Can they show their math? Can they show logic in making that decision? So what are the most important factors? Well, I want to be pain-free, or I want to be able to walk better so I can take my grandkids to the zoo, or whatever it is. What are the factors going through their head? And then, how are you balancing the pluses and minuses? Because there's always minuses, right? There's always potential side effects, but how are you balancing? And I like that last one. Do you trust your doctor? And obviously, this is somebody other than the doctor asking that, but some third party that's trying to figure this out, So, a couple helpful things here. So I stumbled on this. I've never used this, but there is a thing you can get online called the Aid to Capacity Evaluation, or ACE. And you can Google it. It's free. There's training available on the web of how to use it. It's basically a questionnaire, and I'll show you it here in a minute. It's got a pretty good amount of research behind it. It's basically a bunch of questions, very similar to the ones I just showed you, but slightly different, that let you, give you a scaffold or give you an interview that you can use to talk to somebody where you're wondering about their ability to make decisions. It's apparently quite widely used, and there are a number of online tools, but this is, I think, people in the field, I'm not an expert in this, but people that are seem to think it is probably the best one out there. And again, it's free. So I know this is hard to read or impossible to read, but it just mostly kind of reminds me of a couple of these. So starts with ability to understand the medical problem with a sample question. What problem are you having now? Or what problem is bothering you the most? So it gives you very specific questions you can ask. About, do they understand their condition? Do they understand the consequences or the side effects of the treatment, or the consequences of not doing the treatment? No, it's really just nuts and bolts, very, very practical. And it goes on for another half a page, and anyway, I just thought that seemed like a pretty helpful tool. And again, you can get that online free. Now, some other things, some cognitive tests. So I mentioned this, the second one, this MOCA. Before I do that, there's this other test that many of you may have heard about, the MMSE, the Mini Mental State Examination. It's been around for 50 years or something like that. Used to be our gold standard. It is not so much used anymore. The authors of the test, I think, got tired of the fact that everybody was doing it for free, and they realized this is started saying this is a copyrighted thing, you gotta pay us to use it. So it's kind of dropped out of favor for that, partially because of that. So the new, most commonly used cognitive test in practice these days is this MOCA. It comes out of Montreal. Well, that's why I call it Montreal Cognitive Assessment, or MOCA. You can get, like anything, you can get the test and print it up off the internet. But technically, you really should go through training and certification. So even though I've administered this for many years, I had to go through and, make sure I was properly trained, so I'm doing it right and get certified and all that. But the punchline though is it's a 30-item test, as I mentioned before. Normal is about 26 to 30. And the lower the score, the more likely it is that somebody lacks capacity. And likewise, the higher the score, people in that 26 to 30 range very likely, statistically, do have capacity. Not necessarily, but most likely, statistically. So here's what it looks like. Oh yeah, so I already said that, okay. Again, you can find it online. It's really kind of a nice little test. It has, the first one there is it has you connect, those circles have numbers and letters, and you go between a number like 1 to A to 2 to B and so forth, to see if you can keep track of, two different streams of thought, the numbers and the letters. And then you gotta draw a cube, which is a real challenge for a lot of folks, and then you gotta do a clock drawing test. I'm gonna come back to that separately later and show you more about the clock drawing test, because I think that's a real practical thing. Name some animals and so forth. So it's got a lot of different, it checks a lot of things, including memory. It has you try to remember 5 different random objects and so forth. So it's a really good, all-purpose cognitive test. But again, unless you get trained and certified in that, you're probably not gonna be doing that. So what else can you do? What are some practical things that anybody can do? Well, anybody can ask these kind of questions. So we usually start with, or I do, with asking about orientation. Like, do you know what month it is, what season, what year? Notice I didn't say date. So if I asked any of you, what's today's date, some of you might get it wrong. I would get it wrong half the time, because unless I'm writing a check or writing the date on a piece of paperwork, I might know, is it the 5th or the 6th, I don't know. And I don't really care with the patient, but they ought to at least know the month, ought to know the season, ought to know the year in general, right? And do they know where they are, Again, if they're in a facility, they may not know the exact address, but I would expect them to know the name of the facility and that they're in Omaha or whatever, right? Some basic stuff. This is a good short-term memory test, can you remember recent news events? Well, again, I won't go into that. I mean, we've obviously just had an election, and there's lots of stuff there, but sometimes I'll ask people that are sports fans about, the latest Husker football game, and can they remember the score? Who did we play? Do we know the name of the quarterback? Now, again, if they're not into sports, that's not gonna work, and that's okay. But that's I kinda like asking real life questions rather than artificial ones, like remember these random words. Abstract reasoning, so this is kind of an interesting test. Ask people like, how is a bicycle like a train? Can they get at the concept that they are forms of transportation or some version of that? As compared to a more concrete answer, which would be they both have wheels. Technically true, but it's not as abstract or as sophisticated an idea as, kind of coming up with some more abstract similarity, like types of transportation. Or how is a lie different from a mistake, being deliberate versus accidental, that kind of thing. So I mentioned this clock drawing test. So this is really one of my favorites. If you can only do one thing, this might be a thing, orientation and this. That might be a helpful start. So again, a low-tech thing. You don't need a computer, you need a piece of paper and a pencil, basically. And so I actually like watching people do it. Sometimes people have somebody else like a nurse do it. I like to actually watch the patient do it myself. So here's the way I do it. I give them a blank piece of paper and a pencil, and I say, I want you to draw the face of a clock with all the numbers in it. And I stop talking. Some people will go on to the next thing and say, make it say such and such time. I don't do that. I do this first part first and let them do that. Because I want to watch and think about that. If I asked you to do that, how would you do that? How would you put the numbers in? Because it's hard to space 12 numbers. There's no right or wrong. Some people just start at the top and they go around and they can do it okay. At one point, I actually did this for my a classroom full of medical students, and I had them do this. And I noticed that the male students tended to put in the quadrants, the 12 and the 9, and the females just kind of started at the top, and they were accurately able to do it. And I don't know if that is an accurate test or not, but I think women are a little better with visual spatial stuff, and they can somehow space out 12 things, whereas men can't do that as well, so they put it in either way is okay. But if I've seen all kinds of errors here. You go counterclockwise to clockwise, so the numbers are in backwards, or you hit the 12 and you keep going to 13 or 14, I mean, all kinds of stuff. So just, even this part, they can get wrong. So just, anyway, get that done as best they can. Then I tell them, make it say 2:45. Now notice too, this is a little nuance. I don't say put in the hands to make it say 2. I just say make the clock say 2:45, because I want to make sure they get the concept of putting hands in. Someday this test won't work with future generations if everything's digital, right? Because things like that analog clock on the wall may not exist, I don't know. So here's some examples. So normal, 2:45. So these are people trying to make the clock say 2:45. So the normal one you get. But notice on the normal one, where is the hour hand? That's a sophisticated little nuance. It's not on the 2. It's somewhere between the 2 and the 3. You get extra credit if you get that nuance right. That's a pretty sophisticated thought. Like, yeah, at 2:45 it won't be on. Again, I don't take points off if they don't. That person seems like they're tracking pretty well. Now look at that mild cognitive impairment, 2:45. They're looking for a 45 because they don't get the abstract concept of quarter till. So I've seen that a million times. Notice the next one, the moderate cognitive impairment. Here they circled. Notice no hands, but 2:45. So they're trying as best they can. And then finally, the person with more severe cognitive, and again, these are people with dementia. That's the type of impairment we're talking about. They got the circle and they kind of got hands, but they couldn't even get the numbers. But these are real live examples. I'll give you a few more real live examples. So this person, I don't know that I can read. I think they're trying to say cuckoo. So what is that figure at the top? They're trying to draw, I guess, a bird like a cuckoo clock. So they added that little artistic, extra thing. So this person, notice, wrote 2:45. Obviously didn't get all the numbers in the circle or put them in the right place. Notice the hands. In this case, the person instructing them probably did say put in the hands. And that's what they came up with, it's like physical hands. Again, they're not trying to be funny. I think they just literally were struggling, trying to figure out what do hands look like on a clock, and that's what they came up with. And one more. And this is not somebody trying to be a wise you-know-what. They were told, draw the face of a clock, and this is what they came up with.
Face.
And they literally did that. So
It's a nice face.
it is, yeah. Positive. That's good. Not a bad character. So it's a real simple test. Anybody can do, and I think it's just kind of a handy little thing. It gives you lots of information without taking a lot of time or whatever. Okay, so now just a few other practical things. So assessing real life functioning. You heard earlier about ADLs and IADLs, and I won't go into, but many of you already know this. But there are assessment tools you can use to actually rate those. But I'm going to shift gears for the last part now and talk a little bit about the frontal lobes here, my favorite part of the brain. So talked a little bit earlier about that frontotemporal dementia that I kind of alluded to, can fly under the radar. So I won't talk too much about FTD, frontotemporal. Well, I guess I will since I've started that. So frontotemporal dementia, again, much less common than Alzheimer's or vascular or Lewy body, but it's out there. It tends to affect people a lot of times in their 50s. It can occur later, like Alzheimer's, but it often hits people in the mid to late 50s, which automatically makes it harder to pick up, because when you see a 55 or 57-year-old in a clinical setting, the last thing you're usually thinking about is, I wonder if they have some kind of dementia. 85-year-olds, you wonder, because statistically it's much, as you heard from Sadie, much more likely as we age. But you don't expect a 55-year-old. And the other thing I mentioned earlier is people with frontotemporal dementia typically don't have much in the way of memory problems. You can check their memory and it's good. They know what day it is. You can give them those random objects and they'll remember them 5 minutes later and so forth. But they may not do well on some other parts of the testing, like on that MOCA. They may not do well on connecting the numbers and the alphabet letters, because that's a frontal lobe function. Or they try to draw the cube and they kind of really mess it up, because that involves good frontal lobe. The other thing, incidentally, that's on the MOCA, okay, thank you, is there's a tapping test where you read a random series of letters, and you say tap every time you hear the letter A, I think it is. And people with bad frontal lobes, they will tap when they hear an A, but they'll tap with other numbers or other letters as well sometimes, because they have trouble inhibiting. So the frontal lobes really are one of the things that differentiates us from other animals, I think, and they give us our personality, give us drive and motivation, and this last thing, executive functioning. So the ability to plan and organize and sequence all that. So your executive functioning is probably quite good. You got here on time, you had to register ahead of, you had to do a bunch of things to get here where you are today. You had to take time off from whatever you normally do and so forth. So you had to plan ahead. You know, Anita and her crew had to have great executive function. They had to plan a million details to make this all work. So, but people that have bad frontal lobes can't do those things very well. And one metaphor I like to use for the frontal lobes is think of them as the accelerator and the brakes of a car. So they're the accelerator in the sense that they affected by not just frontotemporal dementia, but other things, trauma and so forth. So when you lose the accelerator, you lose motivation. So think of a car that has no accelerator. Doesn't matter how big the engine is, it's not going anywhere, right? So if you lose that function of your brain, you become apathetic. You have no interest in doing things, no energy. Looks like depression, because depressed people often get apathetic too. They don't care about doing stuff, but they also have sadness and sleep problems and appetite problems. People with apathy because of frontal lobe problems don't have those other symptoms of depression. They just have the apathy part. But this is the one that gets them in trouble. This losing the brakes. They lose the filters. That's another way of saying it, right? They just sort of do things and say things without worrying about the consequences, or they get disinhibited. That's the other term we use a lot. And one real life, or one way of thinking about this is, imagine, this is something I tell my medical students, imagine going through a day like the rest of today where any idea, any thought, any fantasy that crossed your mind, you did. You didn't stop to think like, oh, that was just kind of a fun little fantasy, a daydream, I'm gonna keep that to myself. But you actually acted on it like, no, I'm gonna do that thing. So that would be losing the brakes. And we all, you know what goes on inside your head. So we're all human beings, right? But imagine that's kind of what this is like, that these folks will just blurt things out or make sexual advances or get aggressive or do all kinds of things. Instead of, you might be mad at that person that cuts you off in travel. I'm gonna go, catch up with that so-and-so, but you don't do it because you realize it's a bad idea. But if you have bad frontal lobes, you might just do it. And the other thing that happens, their basic personality changes in a dramatic way. They may get, again, more impulsive, but they might also just get more rigid. And that can get in the way of decision making, as you might imagine too. But again, their memory typically is pretty good. How do you assess the frontal lobes? We sometimes will order neuroimaging, and of those, this PET scan is the best one. Not every hospital has access to a fancy PET scanner. We happen to have one, but it's a good way of testing. But the other thing that's really helpful is this neuropsychological testing. That's more practical and very, very helpful. I'll show you, that leads to this last part where we talk about who's who. So who can help? You have a client, a loved one, who knows? You have somebody where you're worried about their potential capacity. Who can help sort this out? And let's say, in particular, you're worried about that frontal lobe stuff. That it seems like their filters are gone, whatever. Or maybe it's more memory, whatever it is, whatever brand of cognitive problem they might have. A neuropsychologist can be a really, really helpful asset. So these are PhD level psychologists. So I'm a psychiatrist, I'm an MD, but these are PhD level psychologists that have extra training in neuropsychology. So not every psychologist is a neuropsychologist. It's a special kind of training that they get. But they can do paper and pencil testing, they can do IQ testing and all sorts of things. Really, really, really helpful. Not a lot of them around, and they tend to live in bigger cities like Omaha and Lincoln, but they are available. A neurologist is a physician who specializes in brain diseases like epilepsy, but also some of them specialize in Alzheimer's disease and other forms of dementia. At UNMC, we have a neurologist named Dr. Dan Merman, and some of you may have heard of him or know of him. But that's all he does for a living, is see people with dementia. He's a neurologist. Some psychiatrists take care, like me. Now, there are general psychiatrists that will sometimes take care of older adults. Typically, they don't do as much with older adults with dementia, but they will take care of older adults with depression and schizophrenia. But then there are geriatric psychiatrists like me that do extra training. And again, we have 4 of those at UNMC, which doesn't sound like a lot, but it's actually one of the bigger groups of geriatric psychiatrists. There just aren't enough of us around, but we actually have, I'm blessed to have 3 other colleagues that work with me in this area. And again, we're trained to deal with things like the behavioral consequences of dementia, the agitation, the combativeness, and so forth, as well as depression and the other common problems with older adults. And then an even rarer breed of psychiatrist is the forensic psychiatrist. Our department, the Department of Psychiatry at UNMC, just hired a forensic psychiatrist, first time we've had one in many, many years. But this is a psychiatrist that specifically deals with that interface of mental health and the law. So these are people that can really do sophisticated capacity assessments and things like that. And I guess that's the last actual, this is hard to read, but there's a, if you want to learn more about this, there's an Elder Justice Decision-Making Capacity Resource Guide online. You know, we can send you these slides and they'll show you the link, but it's like a 50-page document where it goes into a lot of the things I talked about. What is capacity and how do you evaluate it and so forth. So if you really just need some light reading material at night or something, you know, this might be just what you're looking for. Okay, and that's the link to it, but again, we can send you these later. Okay, well, and I will keep you on time for your lunch, but it looks like we might have a couple of minutes for questions, I guess?
No questions online. Are there any questions here in the room?
Just one.
Go ahead.
To see you or somebody else at UNMC, do you have to have a GP, a UNMC GP, or be in their healthcare system?
Yeah, to get into like our clinic, yeah, right now we're there, yes, we are saying that, just because we're so swamped, we need to take care of our internal folks first, in general, yeah.
Oh.
Now, there is just be aware too that there, and I don't know if you'll talk about later, maybe GAC later, or I can just mention it now. So we do have, so UNMC or Nebraska Medicine, we're all kind of muddled together, has a geriatric assessment clinic, you know, where anybody can come from any healthcare system, any part of the state or any other state, frankly, and be assessed if you suspect they might have dementia. It's a one-time evaluation. Methodist has one that's good, I believe, and Madonna, I can't remember, but VA does, yeah, for veterans, VA does. So we're not the only show in town, but I know ours best because I work there. But,
Thank you.
yeah.
Any other questions? Well, thank you again, Dr. Wengel. I really appreciate it.